everyone. Welcome, and thank you for joining us today for the Coronavirus Pandemic Epidemiology COPE Consortium and Update webinar. My name is Stephanie, and I will be your WebEx host. Before introducing our speaker for today, who will review today's program and introduce our speaker, I would like to provide a few tips for using the WebEx platform. All lines have been muted upon entry and will remain muted for the duration of the webinar. Should you have any questions, you may submit those questions at any point during today's presentation by using the Q&A or chat panel and selecting Host or All Panelists from the drop-down menu. Today's webinar is being recorded and will be available upon request. Should you experience any technical difficulties, please use the chat feature on the right-hand side of your screen and select Host from the drop-down menu, and I will be able to assist you. And with that, I would like to pass over the presentation to our moderator, Lynn Wilkins.
Hi, everyone. Welcome to our webinar series of the NCI Cohort Consortium. I, along with Dr. Manouk Shoemaker, will be moderating this webinar. The webinar series, we're having a webinar series, and it's designed to push forward items on our Cohort Consortium strategic plan, which several of you probably know about. The goal of this webinar series is to share best practices for cancer epidemiology cohorts to identify challenges and share possible solutions, foster career development, and provide an opportunity to test out new ideas in a supportive environment. This is the first webinar of our series. We anticipate having at least 2 more before our virtual annual meeting in the fall. As Stephanie mentioned, you can submit your questions on chat, and we'll cover as many as we can at the end of the presentation. But also, if you have topics that you would like to add for us to consider for the webinar series, you can also provide those to us on chat. Now I'd like to introduce our speaker, Dr. Andy Chan, and he will speak on the Coronavirus Pandemic Epidemiology Consortium, or the COPE Consortium. He is a professor of medicine at Harvard Medical School. He's the chief of the Clinical and Translational Epidemiology Unit at Massachusetts General Hospital, where he is also the director of cancer epidemiology. As a gastroenterologist, Dr. Chan specializes in familial gastrointestinal cancer symptoms and cancer prevention. Dr. Chan is a leading investigator in the epidemiology of colorectal cancer and other digestive diseases, with a focus on chemoprevention with aspirin and the interaction of diet with the gut microbiome. In March 2020, Dr. Chan organized the COPE Consortium, which includes over 20 countries. In this webinar, Dr. Chan will provide an update on the progress of the COPE Consortium and the lessons learned so far. Thank you, and welcome, Dr. Chan.
Thank you, Lynn, for the opportunity to talk to folks today on this webinar series. I'm delighted to have this opportunity to share with you our experience with the COPE Consortium. I speak to you on behalf, as Lynn mentioned, of investigators from over 20 different cohorts who have been participating in COPE over the last several months. And we view this as an opportunity for also other groups within the NCI Cohort Consortium to get involved if this is something that they're interested in working through as well. So just to give you some background, as Lynn mentioned, I am an epidemiologist and also a physician scientist. And I think when COVID first came about, we were obviously very interested in understanding how it is that we could play a role as epidemiologists in trying to fight the pandemic. And as cohort epidemiologists and investigators who are experienced with participants in the community and in the field, we felt we had a unique opportunity to leverage our collective skills and our collective infrastructures to really develop a strategy around which we could try to make some inroads in addressing the COVID pandemic, both from the public health standpoint, but also from the standpoint of the interests of individual investigators within the NCI Cohort Consortium. So we launched the COPE Consortium at the end of March, and this is really a consortium that was put together very quickly as a way and as a call for collaboration from investigators across the country who were interested in epidemiological studies of coronavirus, but also as a call for collaboration among investigators from different cohorts within both the NCI community, but also across different research communities, including other NIH-related institutes, as well as clinical trials that are being conducted across the United States and other countries. This effort was successful in terms of being able to garner the interest of now over 20 cohorts across the US, but also with partners in the UK and also Sweden. And we're interested, obviously, in continuing to expand our efforts with the addition of additional cohorts that are interested in COPE, expanding the infrastructure within COPE to allow those studies that are currently participating to take full advantage of the resources that are being developed. One of the key components of the COPE Consortium was the availability of a free downloadable app which could be downloaded onto a mobile phone to collect information in real time from participants in various cohorts across the country. And this was a tool that we felt was critical for the success of COPE in terms of being able to collect data quickly on a fast-moving pandemic, and also allow the flexibility to be able to adjust rapidly questionnaire instruments into different cohorts at during different phases of the pandemic. In addition, given the highly dynamic nature of how coronavirus spread and how different communities have faced different facets of the pandemic at different times, we felt an app-based technology was particularly effective for collecting data from participants that really required, again, updates in information from even a day-to-day or week-to-week basis. So on this slide, I give you some background information for folks on the webinar who would be interested in finding out more about COPE. As you can see here, this is based at Mass General, and we have a website that's currently active that provides information about COPE, including a statement of purpose and mission, but also frequently asked questions from both investigators and also even individual study participants who are interested in understanding how the COPE Consortium works and how our data collection tool works. In addition, it also provides a very easy-to-use toolkit, which includes information about how to develop an IRB application that is very efficient and expedited for individual studies to use, and also examples for email invitations, etc., as well as a place for people to easily download the app so they can see for themselves what type of questions are asked on the app and what kind of information is collected. And the information about the website are provided on this slide and will also be summarized at the end of the presentation. Another place for folks to get some more information about COPE will be in our recent publication in Cancer Epidemiology, Biomarkers, and Prevention that was published in early May, which was a call to action to really solicit participation from amongst individuals in the epidemiological community, and also an opportunity for a description of the rationale behind COPE, and also more information about the actual infrastructure that's been developed, more information about the actual app, and also some additional directions for the future for which we are hopeful that we can take with increasing participation. So for those of you who are interested, I would point you to this publication, which is freely accessible through the ACR CEBP website, and again, is an easy place for people to get some more information at the conclusion of this webinar. So a little bit about background and of why we decided to develop this app and what's been collected so far and what's been the usefulness of the data that's been collected so far. So this app is called the COVID Symptom Study, which was an app that we developed in collaboration with Zoe Global Limited, which was a health sciences company in the UK, as well as with King's College London. And Zoe has been a partner in research studies that we've done for a number of years at Mass General, looking at the ability of a dietary app to help guide personalized nutrition strategies for study participants. When the COVID pandemic hit, Zoe pivoted quickly to assist in development of an app that was designed based upon the infrastructure and backbone of the app that we were using for digital nutrition studies, and essentially allowed the application of this tool to collect information about COVID risk factors, as well as to collect information about the symptoms that people were experiencing of COVID. This has been a service and contribution from Zoe to the scientific community that's been offered free of charge. They provide the app as well as all of the technical support and the engineering free of charge to the investigator community. They have also established a method by which cohort investigators can receive data that's collected on the app back to their individual cohorts, which is a process that they've developed, which again is available free of charge. And they're designing and have designed this app to be something that's available without any commercial intention. So we feel that this has been a terrific partnership between our academic medical centers and academic investigators with a health sciences partner that has a technological know-how and engineering background to get this developed quite quickly. To date, the COVID symptom study has been launched, as I mentioned, in the United States, the United Kingdom, and Sweden, and is really intended to be downloaded by individuals in the general community free of charge, as well as targeted toward individuals that may be involved in ongoing studies, such as cohort studies involved in the NCI Cohort Consortium. To date, it's been able to be used by over nearly 4 million contributors across the 3 countries. Many of those obviously are contributors that are not part of cohort studies, but are part of the general community that have taken this on as a citizen science effort to help contribute to scientific knowledge about COVID. So giving just some very basic information about what's collected. So for individuals that download the app, the first question they're asked is actually if they're a member of a study cohort or if they're a member of the general community. If they're a member of the general community, they then move on directly to questions about their exposure history, as well as their symptoms of COVID-19. If, however, they are involved in a cohort study, they're taken through a very specific consent process by which they consent to information collection for the purposes of scientific studies, as well as for the purposes of public health information collection. And also they've basically consent to that information being sent back to the investigators of their parent cohort for eventual linkage with their cohort data that they've already provided to cohort investigators in the past. Once the individual consents and finishes the consent process, they're taken to a specific screen where they're actually asked to identify or align themselves with a specific cohort. And as you can see here on this screen, the first question they're asked is, are you a member of any of these cohorts? And there's a list of cohorts that's included in the description. And that includes, for example, the Harvard Nurses Health Study, which I am an investigator on, as well as several other cohorts that you may recognize in addition to the Harvard studies. In addition, there are a few clinical trials included on this list, and there's also an opportunity for cohort participants to free text information about the studies they may be involved in. They're then asked specific questions regarding their occupation, specifically if they're a healthcare worker. And the intention of this was to collect some information about the exposure and the unique exposures that healthcare workers have to COVID-19. And if they identify they are a healthcare worker, they're taken to some additional sub-questions related to their occupation. And then they're also asked specific questions about their comorbidities, what kind of health issues they might have. Again, some issues some questions are questions that are offered to people who are not in cohorts, which allows us to look at demographic and comorbidity risk factors for COVID-19. Once they fill out that baseline query, which takes about 3 to 5 minutes, they're then asked to report their symptoms. And this is the key component of the app, which is designed to be updated on a fairly regular basis. They're asked specifically, how do they feel physically right now? If they feel normal, it's a question that they can answer immediately. I feel physically normal, which then ends the questions at that point, and they're direct to the final screen, which is thanking them for their participation. If they actually report they're not feeling quite right, they are experiencing potentially symptoms, they are then taken to this third panel here, which asks them to describe in detail what symptoms they happen to be experiencing with appropriate drop-down menus as to severity of symptoms. This includes questions about fever, cough, fatigue, a loss of sense or smell, headache, skin rashes, etc. When we first launched the app at the end of March, we asked about 8 different questions related to symptoms, and currently we're asking 12. So the number of symptoms we ask about has expanded as the knowledge of COVID-19 related symptoms has grown over the last several weeks, which I think illustrates the power of an app to be able to be flexible in asking new questions as hypotheses develop over time. This schematic, which is also available on our COPE website, gives you just a very 360 view of the type of questions that we ask about. This is on the left-hand side in the white area are baseline questions that we ask about health and well-being and baseline characteristics. And then on the right-hand side in the gray box, we ask these questions on a daily basis, which is the questions about their symptoms. We also ask them about whether they've undergone any testing for COVID-19, including their results. And again, illustrating the flexibility of the platform, initially we asked simply about testing of any kind, but over the last several weeks, we have now specified the question to provide, for participants to provide information on whether that test is an antibody test versus a swab test. We also now provide an option for participants to list their testing history, as we've now reached a point where many participants are actually requesting or having testing done at multiple time points. So we'd like to be able to collect that information as well. So I wanted to take you through some of the initial data that we've collected from the app, which I think has been illustrative of the sort of ability of the app to provide some actionable information for public health authorities. So one feature of the app, again, is that we are able to essentially crowdsource information by collecting symptom data from a large number of participants. And this, again, includes participants from across the general community, as well as individual participants within specific cohort studies. And this actually has resulted in the ability for us to track or survey symptoms across a large population. This process is enabled by the fact that the regular can process by the app, or the regular conditions of the app for community members as well as for cohort participants does permit the use of de-identified data for public health purposes. And so we're able to use this de-identified information to gain a geographic landscape, if you will, of where COVID symptoms are being experienced. So within the app, individuals are asked to identify what postal code or zip code they reside in. which gives us the ability to provide some information as to where across a different geographic region there might be a large proportion of symptoms. I'll show you data here that was first collected in the United Kingdom, where the app was launched several weeks before it was launched in the US, where a large number of participants, in this case almost 2 million people, reported symptoms on the app across the UK and provided postal code information as well. As I can show you on this slide, which is available in publication form in publication in Science from May of last month, we show here that in the blue map, this is obviously the United Kingdom. The areas that are darker in blue shows those areas where there's a higher proportion of users. The second map, which is labeled Any Symptoms in purple, shows you the areas around the UK where there was a high level of symptoms being reported at the end of March in early April. And the box below that second map shows you the exact symptoms that were being reported. As you can see from below, that there is a large number of participants reporting, for example, fatigue and cough, and a relatively smaller number of participants reporting symptoms like diarrhea, anosmia, or fever. So one of the key findings was that fever was actually a relatively uncommon symptom being reported by individuals, which was contrary to very early reports of COVID that were emerging from China and other countries where it was felt that fever was a very important symptom, but turned out to be something relatively rarely reported in our app. We also noted that there was a ability of the app to collect complex symptoms, meaning individuals that reported more than one symptoms, as you can see in the third map. And then finally, you can see the distribution of testing that was in the UK at that time. The gray shows you the areas around the country where testing was being conducted, as well as the orange showing areas where testing was emerging, where there was a lot of COVID positive testing, and the green shows you the areas of the country where there was a large degree of COVID negative testing. You can see that actually the COVID positive and COVID negative testing was not well matched with actually where people were reporting symptoms, which illustrates how patchy and fragmented testing was in the UK at the early phase of the pandemic. We collected similar data in the United States across the country through the COPE. And as you can see, the middle graph of the US, you can see in purple those areas of the US which in early to mid-April were parts of the country where we had the most folks reporting symptoms in the US. Again, similar to the UK, fatigue was a very common symptom. Cough, anosmia, diarrhea, less common, and fever, relatively rare. The gray on the right shows you again the mismatch between those people on the app that were reporting a receipt of testing with the areas that were reporting symptoms in purple. And this was all based in the publication from CEBP that I shared with you at the beginning, which gives you a good overview of what we've collected so far in the COPE. Together with our collaborators in the UK, we actually used the symptom data to develop a predictive model of symptoms that tended to be associated with a positive COVID-19 test. And this was through a simple logistic regression model using all the symptoms that were collected on the app in relationship to those people on the app that reported a positive test. We then took that regression model and used it to predict COVID symptoms within those people on the app that had not been tested for COVID. And this was through a publication that you can download from Nature Medicine that showed that the key symptoms that were associated with being positive for COVID were loss of sense of smell or taste, as well as skipped meals or fatigue. And these were really key symptoms that were the most predictive of having COVID-19. This was then, as I said, developed into a prediction model based on symptoms, which had good performance. We had sensitivity and specificity of over 70% in the ability to predict COVID positivity in a separate model that was based on our US population. More recently, we've extended this model to the country of Sweden, where we've taken symptoms of COVID reported from the Swedish population and used that as a way to classify who we think might be COVID positive. And again, the model has performed well with a sensitivity and specificity of about 70%. What was really key from this research and what was key in this initial publication was the strong association of loss of sense or smell with COVID-19. It's hard to remember it since we've been living through COVID for so long, but very early on that was actually not recognized widely as a symptom, and only recently has become appreciated as a symptom and has now made guidelines both from the CDC and WHO as a symptom that clinicians should look out for COVID. In addition, it's been borne out in other data sets and it's been shown to be quite predictive. So this loss of sense or smell is now data that we're collecting quite actively and is being collected quite actively from public health authorities, and seems to be also a very early sign of COVID-19, which I think speaks to the importance of finding symptoms that predict COVID-19 early, given that there is an estimated 25 to 30% of community-based transmission from relatively asymptomatic or lightly symptomatic individuals. This prediction model has been used to help us identify potential hotspots in real time across the population. To use help warn public health authorities that there might be a surge of cases that could be coming into the hospital that may overwhelm the public health system. So this was data that we first looked at in the UK in collaboration with the area of Wales in the UK, in which the Public Health Authority actually requested that this data come into their system on a regular basis to help inform their public health response. And this is a little bit difficult to get through easily, but I'll try to do so as best I can. If you can see here in panel A, these areas of dark pink are what we consider hotspots related to symptoms. And these are areas that, with our symptom classifier, that would be predicted to have high levels of potential COVID infections in the population. If you can see here on April 1st, there are relative areas that are hotspots within Wales. But if you look here at the bar graph below, this bar graph, the bar graph represents actually confirmed cases of COVID. And I want you to focus on the colored bar graphs, which actually represent the actual reports in different areas within Wales. And as you can see here, if you look at actual confirmed cases, they don't actually track that well with confirmed cases until you look at data about 5 days later. So as you can see here from this graph here, you can see that the number of cases that start to be confirmed in Wales starts to rise as of April 6th and is sustained for 4 or 5 days afterwards. So the hotspot that was identified on April 1st looks like it associates with an increase in confirmed cases as of April 6th or April 10th. Similarly, in panel B, you can see here that there is a hotspot here that actually tends to, again, associate with the area of Wales, which if you look here on April 11th, does not correlate with a high number of confirmed cases, but actually if you track things out further, you start to see here that there are starting to be rises in confirmed cases as of April 14th through the 16th. So in general, the symptom surveillance and the ability of the prediction model to predict COVID seems to be able to do so within about 5 days earlier than you start to see confirmed cases in the population based on testing or hospitalization, which can provide some valuable time for public health authorities to get mobilized and also overcome some of the burdens and the imbalances that we have in test availability across a large population. We've also been embarking on a number of other analyses using the data from the app. Again, this is across all individuals reporting information on the app across both the United States and the UK, which is a mix of individuals that are both community members as well as some individuals that are members of specific cohorts. As you can see in both the US and the UK, which use very different classifications for race and ethnicity, you can see that there are disparities in terms of COVID-19 according to race ethnicity. You can see quite clearly here that individuals that are non-white, including Hispanic or Latinx or African American or Asian, tend to have between a 2 to 3-fold higher risk of testing positive for COVID-19 compared to whites in the US. Of course, part of this disparity may be related to differential access to testing, although we would assume that probably there would be less access to testing amongst these non-white communities. But despite adjusting for access to testing using inverse probability weighting, we still see that these types of disparities persist with only partial attenuation of the odds ratios, with, again, odds ratios in the 2-fold higher risk range for individuals that are Latinx or African American. We did a variety of analyses also adjusting for other factors that we had collected in the app, including comorbidities, and found that these risk estimates did not change appreciably, which I will show you, which I showed you in this particular model here, the second model in blue. But we also consider the possibility that differential geographic distribution, differential population density, or differences in socioeconomic status may explain these disparities. So we also adjusted for socioeconomic indices based on our zip code data, as well as other exposure data we collected in the app, and found that these disparities did not completely attenuate. So the gray bars, for example, here represent the multivariate adjusted odds ratios for comorbidity that are adjusted for comorbidities. When you additionally adjust for socioeconomic indices, as you can see in the black just below, there is a slight attenuation of the odds ratio, but not complete attenuation, such that you continue to see disparities according to race ethnicity despite adjusting for socioeconomic status, suggesting that, again, there are probably systemic inequalities that could be responsible for the higher risk of COVID-19 in the Hispanic Latinx community, as well as the African American community, which includes obviously some data elements that we don't collect on our app with respect to the type of exposures that they have in their community, their type of work exposures, et cetera. So I think this is an area that we hope to delve into more deeply in the future. As I mentioned early in the app, we also ask if individuals are healthcare workers. And so we've done that both in the UK and the US. And we found overall, not surprisingly, that frontline healthcare workers are more likely to report being tested for COVID-19 and also having a positive COVID-19 test. In fact, the risk was quite elevated, with an almost 11-fold higher risk of individuals that are healthcare workers testing positive for COVID-19. When we do inverse probability weighting and other strategies to account for the fact that healthcare workers are more likely to be tested, we see about a 4-fold increased risk in COVID positivity. So this additional occupational risk is really evident within individuals on the app. In the app, we've also asked if individuals have adequate access to personal protective equipment, and we found that individuals that actually had inadequate access to personal protective equipment had a higher risk of developing COVID-19. This was particularly seen among individuals, not surprisingly, that had a high degree of interaction with people who were known to be COVID-19 positive or suspected to be COVID-19 positive. Illustrating, again, how important personal protective equipment are in protecting healthcare workers from getting infected. We also found very important associations related to the type of practice site that people work in. We found, not surprisingly, that healthcare workers, frontline healthcare workers that worked within inpatient hospital settings or nursing homes or home health settings had the highest risk of COVID-19. And they were also the populations that reported the highest levels of inadequate PPE access, including the need to reuse PPE on a regular basis or inadequate PPE, illustrating again the association between practice site and COVID vulnerability has a lot to do with sort of resource allocation and also the ability of individuals to access appropriate protective equipment. This may also have racial and ethnic disparity associated with it. We noted that frontline healthcare workers that were African American or Hispanic had the highest risk of developing COVID compared to white healthcare workers. And they also were the group that were more likely to report inadequate access to PPE and work in hospitals and nursing homes where PPE disparities were the greatest. Finally, with respect to cancer, we've been obviously interested, given the number of individuals in the cohort consortium studies that are cancer survivors, at understanding the association of cancer with risk of COVID-19. This has been an area that's been actively investigated in a variety of settings, many of which were mostly settings hospitalized patients with cancer, finding that people who had cancer that were hospitalized tended to do worse. We were actually interested in knowing, even among community-dwelling individuals, were people living with cancer also more likely just to develop COVID-19 or get tested positive for COVID-19. And as you can see in our data here, there is almost a twofold increased risk of testing positive for COVID-19 among those individuals that identify on the app as living with cancer. In addition, for those individuals that report being on chemotherapy or immunotherapy, there's about a 2 to 3-fold increased risk of testing positive for COVID-19 as well. So this illustrates the ability of the app to not only look at risk factors of COVID-19 with respect to worse outcomes, but also just being able to be in a position to look at risk factors for even testing positive for COVID-19. Recently, we have launched as well with our collaborators at Zoe the app in Spanish, which I think is particularly important given the disparities that we've seen on the app in terms of likelihood of testing positive for COVID-19 among the Hispanic and Latinx community. In addition, we clearly know from recent data that's been emerging from the new hotspots of the pandemic in the South and Southwest that many of the areas that are reporting record increases in the incidence of COVID are reporting these increases predominantly among the Latinx and the Hispanic communities, as well as younger individuals. So we would like to be in a position to be able to collect this information using our app. So we've designed the app in Spanish and now provide web support as well for individuals who are primarily Spanish speaking. So in the future, we are very interested in working using this app platform in a variety of other directions that are relevant to epidemiology. In particular, as you can see from the way we've designed the study and the way we've sort of stood this up rapidly in a population setting, that we've relied predominantly on individuals self-reporting information with respect to both symptoms and testing for COVID-19, which certainly has its limitations in terms of the access to testing that individuals may be experiencing could be differential. So we are now hoping to link with other studies that may be able to provide us an opportunity to actually test objectively individuals on the app for COVID-19, at least using home serology-based testing, if not also novel methods of testing based on saliva or swabs that can be self-administered. So we've recently entered into a collaboration with other groups that are now offering in a limited setting home serology-based testing, which will be very informative going forward. In addition, there are other symptom surveillance studies that are currently active, both in the United States and in other countries that we've been actively collaborating with. There is actually now a coronavirus consortia across the country that are motivated to really combine data sets to provide more information across the international community about COVID-19. And so we've been linking with them to do some additional validations of the data collected on our app with their apps or their web-based studies, and also doing analyses where there is insufficient information. For example, there is a very high interest in understanding the association of being pregnant with COVID-19. Each individual app or each individual symptom surveillance study has only a limited number of pregnant individuals. So linking together our data sets will be quite informative. Finally, we're interested in deploying the app also as not just an epidemiological tool in large populations, but also in very specific study populations. So we've been connecting with community-based initiatives that are interested in using symptom-based tracking for clinical trials, for outcome studies. Also have been working actively with county and city health authorities to understand how to use the app in a large population-based setting, both for incidence prediction, but also as a way to provide outreach to vulnerable communities that are not being tested at adequate level. And then finally, there's a high interest in university communities in developing strategies for how to reopen their campuses for the fall. And symptom surveillance studies may offer an opportunity for us to help in that very massive undertaking. So I want to close by just recognizing, again, how valuable it has been to be part of a team that has really been able to pull this together, to provide some scientific contributions to help fight COVID-19 in our communities. I want to recognize key individuals within our group at MGH that have been instrumental in developing the app study, both from the standpoint of getting it deployed in various populations, but also in some of the initial data analyses. Includes David Drew. In addition, we have many other analysts and study investigators at MGH, as well as King's College London, that have been actively working with the publicly available data at this time. I would highlight that the data are publicly available and in a de-identified data set that can be accessed for individuals to do studies with. But we also obviously are interested in allowing cohorts to get the data back to their individual studies so that they can analyze the data if they wish in connection with data, again, that they've collected from their individual cohorts. I also want to recognize the individual contributions of the team at Zoe, who's provided, again, the engineering for the app free of charge, and again, collaborators at the Harvard School of Public Health, King's College London for their scientific collaborations and contributions. And also want to point out the contributions of the Stand Up to Cancer Foundation. Very early on, we partnered with them to help push the app out to their networks, which has been enormously helpful, given their tremendous presence on social media, but also with their ability to connect with the cancer survivor community. And that's been enormously fruitful. And I think it's a testament to their ability to connect people across the cancer research community in a common cause like fighting the COVID-19 pandemic. And finally, I really want to thank the now almost 4 million people actually who have contributed information on the app across the different countries, especially those members of cohort studies for whom the data will be especially valuable going forward as we are able to link that data with data that they've already so kindly provided our individual cohorts over the years about the risk factors for cancer and other diseases. And with that, I'll take questions, and we'll leave this slide up. This gives all the information as to how to get in touch with us should you want to join COPE if you're not already a member, but also for more information about our studies, and also more information just about updates on the new findings that we have related to the research. Thank you.
Great. Thank you, Dr. Chan, for an excellent presentation. This has been really, really informative. So we would now like to jump into questions from our audience. So if you haven't done so yet, or you've been waiting till this part of the webinar, feel free to submit those questions using the Q&A or chat panel that is on the right-hand side of your screen.
So thank you, Dr. Chen, for your very interesting talk. And it's very impressive to me to see how quickly this was set up with multiple international collaborators and amidst the turmoil of countries going in lockdown. I have a question that came up from the floor. How is the data sent back to the participating cohorts? And also, what linkage is possible? For example, linkage to cancer registrations, death certification, hospital episode statistics where available.
Yeah, so they're a very good question. So essentially, there is really data flow in two directions. So the first flow of data comes from the individual cohort investigators. It's not really a data flow, but data request. Really, your individual cohort investigators, for example, the PI of cohort X, will send an email out to their participants. Would you please join this effort and download the app as part of this effort? If the cohort participant agrees, then they're consenting through the app to provide data to Zoe and the COPE Consortium that will be used in a de-identified way for public health information and public health response. And that de-identified data will be available for the scientific community to use for the COVID-19 response. And that's the data that are freely available in a de-identified fashion through publicly accessible databases. And currently that database is set up through the Wellcome Trust in the UK, which provided funding for that data repository. If the cohort wants to get the data from individual cohort members back, then they will basically make a request from Zoe. Zoe will then send the information from their servers to the individual cohort using a special hash system where the individual cohort identifiers, in this case usually it's email addresses, are hashed so that nothing can be corrupted in transit. And the code for that hashed email is given to the cohort investigators to use to basically de-identify the data once it's received at the cohort, and the cohort can then take that data and link it with their individual cohort IDs going forward. Most cohorts are really interested in this data. At some point when this pandemic hopefully has run its course, and of course that's very hard to determine at this point, with the idea that they're going to want to link this to data that they've collected historically in their cohort members, as well as maybe additional data they collect on their cohort members through additional surveys or REDCap questionnaires, et cetera. So, it really depends on each cohort and what their individual needs are as to when they want to actually have that data sent to them. And I think that will be, again, on a case-by-case basis as to what individual investigators want to do and when they want to do it, when they want their data to be sent back to them.
Okay, thank you. And the next question is, have you thought about adding questions about behaviors in the app, such as mask wearing, and where living situations, such as extended family situations, taking into account for the disparities?
Yes, it's a great question, and we have added questions over time, which I didn't have a chance to get into deeply, but we have added questions over time, which have included questions about social isolation. So we do ask individuals sort of what level of social isolation they've been basically adhering to. So they asked, for example, they're asked, are you staying at home all the time? Are you going out for just exercise? Are you going to the grocery store? Are you going to see the doctor? So there are a series of questions that people are asked approximately weekly regarding how much they're adhering to sort of, stay at home as much as possible directives. They're also now asked about mask wearing and what type of mask they're wearing. Are they wearing cloths, surgical masks, or N95? So we are asking that question of participants as well.
Could Hispanic or Latin be defined? How extended is it? And do Spain and Portuguese citizens qualify? Very good question.
So we are at this point available in the United States, the UK, and Sweden. The app is not available in any other countries at this time. So it's not available in Spain or in Portugal or Latin America. And that really has to do with resources, just the resources that are needed to get the app approved in the different countries by the app stores is quite a large undertaking. So at this point, we just haven't had the resources. Zoe hasn't had the resources to really be able to deploy this in other countries. Obviously, that could change, and certainly, we're actively trying to identify ways to support this, and if we can get specific funding to support the app in other countries, we'll certainly try to do so as quickly as we can.
Okay. Does your consent address broader data sharing of de-identified data beyond the specific consortia? And please comment on the data sharing of the larger group, community, as well as cohort, given the public health importance of the pandemic and the advantage of broad data sharing, especially with public health authorities.
Yes. So there's a general terms and conditions that is available or is pushed to all participants on the app beyond the study-specific consent. So the study-specific consent that we have in the app is designed for us to be able to link data back to the parent cohort, but the terms and the conditions of being an app community member, which is provided to everybody on the app, irrespective of their membership on a cohort, it does really request and require participants to allow de-identified data to be shared with the scientific community in de-identified databases. And that's the database that I mentioned was available to Trust. And that's the data also that are being used to connect with other surveillance tools, other apps that are currently available across the US and other countries, as well as other sort of crowdsourced symptom surveillance information.
Okay. I wonder if it's too late for other cohorts to join this collaboration, and also some cohorts, participants join for a very specific purpose, for example, to aid research into cancer. So how should cohort investigators balance the needs to honor the primary goal of the existing cohort studies with the immediate needs to conduct COVID-19 research?
It's a great question. We do want to encourage new members, and we have been welcoming new members, on a weekly basis. We do have discussions with many cohort investigators and have added new cohorts on a regular basis over the last several weeks. So it's definitely not too late for cohorts to join. Certainly, this being obviously an NCI-sponsored webinar, we do have an interest, obviously, in making this useful to the NCI cohort consortium and individuals that are involved in NCI cohorts, which is why we have provided some additional focus on cancer as being, for example, an exposure variable that we're interested in collecting information on. But we've also been very active in promoting the app in other cohorts that are not cancer-oriented. So this includes NHLVI cohorts, or cohorts even with NIAID. The NIA, we have an involvement with the National Institutes of Aging. So there's definitely an interest in providing this information across different cohorts, not just for the cancer community.
Okay. I'd like to hand over to my co-moderator, Lynn, to see if she has further questions to add.
Okay, great. So have you learned anything about asymptomatic individuals?
Great question. So we are, I think, uniquely positioned in our ability to collect data from people who were previously healthy who become symptomatic. So one of the key ways we try to promote the app is that you should, really aim to use it whether you feel well or not, and continue using it whether you feel well or not, so that we can capture in real time when people transition from healthy to symptomatic, which allows us to really capture, I think, those very lightly symptomatic people or people that are quote unquote pre-symptomatic that eventually develop symptoms, because there is obviously some confusion around what exactly is the proportion of community spread that's due to people being truly asymptomatic. And I think it's clear that it's not just truly asymptomatic, but also people that are pre-symptomatic or lightly symptomatic. So I think the app does allow us to be able to collect information on that group of individuals, which we don't collect very good information on from hospital records or registry data at the CDC level, for example. So we do anticipate being able to do more, collect more information on really early symptoms of COVID. And that's really been borne out, for example, by our studies looking at loss of taste or smell. That's really something that seems to be a very early sign and seems to actually occur, several days before the more severe symptoms like shortness of breath or fever.
Thank you. I think that we are about to close. We wanted to pass on an email. I know there's more questions that we didn't get to, but we wanted to pass on an email that people could use to forward questions.
Yes. So if you look on this slide at the end, the website is listed below, the www.Mongan Institute website you can look at. In addition, the email that people can connect with is predict, PREDICT, at mgh.harvard.edu. But you can also email me directly, which is ach@partners.org. Also, you can access the webinar. There's also Twitter is a good way to get a hold of me as well. So there's many outlets for us to connect, especially if you're interested in using the app within your own cohorts or have specific questions about the data we've collected. We're happy to set up a time to meet with you individually as well.
Okay, great. And then if people can't remember that, they can also send the cohort consortium, NCI cohort consortium at nih.gov emails, and we will forward them.
Yeah. And I just sent an email address to the chat. I thought it was on the slide, but it may not be on the slide. So there's an email address there as well as the web link there.
Well, we certainly want to thank Dr. Chan for a very interesting talk and a successful first webinar. So, and thank you all for joining. We had over 300 participants, so excellent. Thank you very much.
Thank you.
Goodbye, everyone.